Our final subject of this edition of ACCEL features a discussion Anthony DeMaria had with Dr. Virend K, Professor of Medicine and Cardiovascular Disease at the Mayo Clinic in Rochester, Minnesota, on obstructive sleep apnea and the risk of sudden cardiac death, a longitudinal study of 10,701 adults.
So, Virend, why don't you give us the background of this study relating obstructive sleep apnea to sudden death?
Thank you, Tony. We've all heard about people dying suddenly in their sleep. Reggie White, for example, some years after retiring, died suddenly and unexpectedly in his sleep. Now, Reggie White had significant sleep apnea. We knew that. We also know that he stopped using his treatment around the time that he died. So the issue is, does obstructive sleep apnea lead to death during sleep? And also important is why this happens. And the first part of the work we did in this area was looking at people who had sudden death. And what we found was if you had sudden death and died in your sleep, you were much more likely to have obstructive sleep apnea than if you died during the daytime. And this set the stage for the next question, which is, yes, maybe sleep apnea predisposes to dying during the nighttime, but would you have died during the daytime the next day or the day before? In other words, we didn't know whether sleep apnea actually increased your overall risk for sudden death. And that formed the basis for the paper that we're talking about right now. And in this particular study, we looked at about 10,700 people and looked at whether or not they had sudden death and whether this could be linked to them having sleep apnea. And indeed, what we found was that when we looked at the predictors of sudden cardiac death in this population, the usual culprits stood out: coronary artery disease, cardiomyopathy, heart failure, non-sustained VT, age, high blood pressure. But what also came out was that if they had obstructive sleep apnea, particularly if they had obstructive sleep apnea causing severe nocturnal oxygen desaturation. In other words, if their apneas were bad enough that the oxygen level fell significantly during sleep, that raised their overall risk for sudden death, independently of all of the other usual variables that we know and love.
So this was a retrospective study, and that always gets a bit difficult since there are so many potential variables that can influence sudden death. Your findings were that sleep-disordered breathing was an independent predictor, as I recall, particularly related to reduced oxygen saturation at night.
Correct. And then, as with any retrospective study, we have the usual pitfalls in terms of how we interpret the data. And we have to recognize that these data do not definitively say that sleep apnea causes sudden death. But what they provide is very strong evidence that sleep apnea is a likely mediator of sudden death in a population coming to the Mayo Clinic, for example. So we have these various caveats that we have to keep in mind. But certainly, despite the fact that this was retrospective, we tried to look at as many possible confounding variables as we could. And despite the fact that we covered a number of these variables in the multivariate analysis, the severity of oxygen desaturation really stood out as an independent predictor. And this harkens to other cardiovascular disease conditions. When we looked at atrial fibrillation in the past, for example, again, it was the severity of nocturnal oxygen desaturation that predicted the development of incident atrial fibrillation. So I think a message that's beginning to emerge from these studies is that maybe it's how low your oxygen falls at night that is a key noxious agent in causing the development of a cardiovascular condition or a cardiovascular event.
I was interested that one of the variables that you didn't look at was whether or not the patients were on treatment.
Right. We didn't look at drug therapy in any significant extent. Now, that is correct. But what we did have was, whether a patient had a device or not, and looked at whether the device fired or not. And so we do have the device variables, but we do not have a detailed assessment of their therapy.
What about CPAP?
We do not have CPAP, and that's another important consideration. While these data would suggest that maybe sleep apnea would predict the risk of sudden death, the data do not address the very important question of whether treatment of sleep apnea would attenuate that risk to any extent.
What do you think were the pathophysiological mechanisms responsible for sleep apnea causing sudden death?
These could be several. When you have apnea, your oxygen level falls, and that's a trigger for chemoreflex activation. The sympathetic response to chemoreflex activation results in significant vasoconstriction with marked increases in blood pressure. Now, when you have this increased afterload in the setting of severe hypoxemia, CO2 retention, and respiratory acidosis, what you have is, in a sense, a perfect storm for developing a cardiovascular event. So the things that we think are probably mediating sudden death in these apneic patients are probably acute myocardial infarction, probably a fatal ventricular arrhythmia. And I say fatal ventricular arrhythmia because when you look at people with devices who also have sleep apnea, the devices tend to fire at night and fire because of the development of a ventricular arrhythmia, suggesting that sleep apneics are significantly prone to ventricular arrhythmias during the night, which is the time when they're having the apneas. So we have probable myocardial infarction, we have the likelihood of ventricular arrhythmia, and something else that's emerged recently is our data suggesting that people with sleep apnea may be at heightened risk for pulmonary embolism. So I cannot rule out the possibility that maybe some of these sudden deaths may be linked to a pulmonary embolus. And we know that apneic patients tend to have a greater level of coagulability, a predisposition to thrombosis, and now with emerging data, maybe a predisposition to pulmonary emboli.
So this really raises the interesting question of how to incorporate assessment for sleep-disordered breathing into the care of patients with cardiac disease, recognizing the important role it plays in congestive heart failure and whatnot. How has these data changed your practice? Are you using it to decide on ICD placement, for instance, in those patients who are borderline? Are you doing increased polysomnography in patients with large MIs? How have you actually used these data?
What we're doing, certainly at Mayo, is being very sensitive to the presence of sleep apnea in our cardiovascular patients across the board. If they have atrial fibrillation, if they've had a myocardial infarction, particularly if the MI has occurred at night, if they've had an ICD fire during the nighttime appropriately, then we look for sleep apnea in these people. And we don't really change the nature of the cardiac treatment in these patients. We are more inclined to more aggressively treat their obstructive sleep apnea, on the supposition that treating the apnea would then attenuate the additional risk that sleep apnea imposes. Now, having said that, what is very severely lacking in the whole sleep apnea cardiovascular disease continuum is the absence of randomized clinical trials showing that treatment of sleep apnea actually prevents a heart attack or prevents ventricular arrhythmia or prevents atrial fibrillation or prevents sudden cardiac death. So really, that is the vacuum that exists in our understanding of sleep apnea's role in cardiovascular disease. And fortunately, many of these trials are now underway. So I'm hoping in a few years we'll be able to incorporate treatment of sleep apnea into standard of care for cardiovascular patients with established apnea, assuming, of course, that the data do indeed show that sleep apnea decreases overall cardiovascular risk.
This is certainly interesting data showing clear association between sleep-disordered breathing, especially nocturnal oxygen saturation and risk for sudden death. Probably something useful to sleep physicians as well if a patient's referred to them for that problem and also has cardiac disease. This might alert them to get in contact with their cardiology colleagues. Thanks very much for sharing this with us.
Thank you, Tony. If I may add one more thing, is that you bring up a very important point, and that is maybe we should be particularly sensitive to the cardiac disease patient with severe apnea. And so what we have in working with our sleep clinic colleagues here at Mayo, we've developed a fast track. So if we have a patient with heart failure or cardiac ischemia or severe hypertension whom we think has a very high likelihood of severe obstructive apnea, we are able to call our colleagues in the sleep clinic, get them on the fast track, and get them evaluated and treated with some urgency.
That's very important and very useful to the practicing community. Again, thanks for being with us.
Thank you very much, Tony.
And that concludes this edition of ACCEL for April 2014. For details about studies discussed on ACCEL, refer to the written summary that is included as a PDF file on this disc. This issue of ACCEL qualifies for up to 4 Category 1 CME credits. To obtain CME credit, go to www.audiodigest.org/online testing. This is Alfred Beauvais for the American College of Cardiology. Thanks for listening.